Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect podcast. Dan Carter back in the studio this morning. Treatment room. Got out of Brown with me. How are you doing this morning?
I'm here.
You're here?
We're doing it. This is a different setup.
I know
than
you
the last
haven't
time
been
I've
in
been
for
here.
the new one, yeah.
I know. I walked in. I'm like, this is different.
We're changing things up.
I know. It's a good change though. It's not a dramatic change. Like
Not dramatic.
Not like when we tried to go into the recovery room and
That did not go well.
We lost like 2 whole podcasts.
I know. We talk about having an actual studio one day instead of the treatment room, but I just worry that
It's gonna be a scary day.
Yeah, we're gonna lose the magic behind the podcast. I feel like this is our comfort zone.
We have a nice ambiance in here.
Yeah, and it's like where we're comfortable.
Mm-hmm.
You know, this is where we're like working on horses. This is where we like the magic happens.
And then one day we're gonna be in like some sterile room, and it's gonna be weird.
Well, I can do it.
I don't know. Well, we'll get there when we get there.
You know, one day we'll try an outdoor podcast maybe. So we're going to dive in today. I know we briefed on this in one of our first podcasts, but a lot of questions arise around this condition. And so we're going to take a little bit of a deeper dive today. We're talking about PPID, pituitary pars intermedia dysfunction, dysplasia. There's another D that's in there. Just depending on what paper you read, what the D stands for.
That's true. Yeah, I never thought about that, but there is you can interpret it lots of ways. But yes, or equine Cushing's, as we call it.
Cushing's is the most common term.
Yes,
they're pushing us more towards this PPID, gives us a little more specific.
Right, because I think the reason we started calling it Cushing's disease was because it presents so similar to Cushing's disease in dogs.
Correct.
Which we've very well documented, lots of treatment plans for it, but when we get into the nitty gritty of how it works, it's actually very different. It's a very different disease, and so we have to thus treat it very differently. Even the way we diagnose it is kind of different. Like I don't think that's how they diagnose it in dogs. So, but we're us in the equine world. We're kind of 20 years behind everybody else. So
a lot of times we are.
We get stuck with the names that have already been established.
We get the name, and then they're like, we should change that. I mean, it took us how many years before we could call it asthma?
Yeah.
I mean, we were close to 50. I mean, I remember when I was in school, it was like, do not call it asthma. It's not asthma. It's recurrent obstructive airway disease. Because we couldn't, and it started as COPD. Yeah. And then like, oh, that only happens with smokers, and horses don't smoke.
Even though it's the exact same presentation and everything.
Same thing.
Except the horses aren't lighting up. But
yeah. They
told us the same with navicular too, though. We're not in school. They're like, you're not allowed to call it navicular disease anymore.
I'm pretty adamant about that one.
I know.
That's a very specific condition.
They're like, palmar heel pain.
Yeah, it used to be podotrochlear syndrome, caudal heel pain. They had all kinds of names.
Oh yeah.
So yeah, names.
The old that's a common theme on this podcast is weird names of things. But let's talk about Cushing's.
Let's talk about Cushing's, PPID.
So everybody's probably heard of this. If you have horses, especially if you have older horses, you've probably heard of this disease. We say that it affects all breeds, males and females. Typically, our age range is going to be horses that are over the age of 15 are kind of our little hot spot of where we start seeing things. But apparently it's been reported in horses as young as 7.
I wonder, because I had one in a 7-year-old and I could not control that horse. Like we had it up to 5 milligrams of pergolide.
Wow.
And this is on actual percents. We're slinging 5 tablets in the same day. Not even getting close to regulating. And I really wondered if those horses are actual, it's not a PPID as much as it is like a pituitary adenoma.
Yeah, like an actual pituitary adenoma.
Right. So I think in these really young horses, because if you look, most of the horses are really young with this. We really have difficulty controlling those. And I think it fits better with an actual pituitary adenoma. The trouble is we don't get to do brain MRIs. So
I don't really have a good way for doing that yet. So
it'd be so cool if we did.
Maybe one day.
I mean, we're getting closer.
Yeah.
We're CTing more things than we ever have. MRing more things than we've ever had.
All it takes is a nerd to map it out and figure out what's normal, what's not. So.
Yeah, there was actually some nerds in Germany that mapped out a way to go into the carotid artery, and they figured out the pathway through the blood vessels to the brain to actually get to the pituitary gland.
Wow, that's pretty neat.
Yeah, it was about 7-8 years ago. I remember reading that paper, and it was really cool. I mean, I don't know what you do with that.
Yeah, I was like, I don't know what your goal is, but I mean, but you can do it.
You can get there.
That's a start.
So they figured out how to drive a stent all the way up to the pituitary gland, which I thought was... And for those of you who want, pituitary gland is like right in the middle of the brain.
Yeah.
It's right next to the hypothalamus. It's right in the middle. So if you think about, frontal lobes, and you think about the brain, and, I always say it looks like a walnut,
Yes.
And if you were to split the brain right through the middle and go right to the middle of it, that's where the pituitary gland lives.
Yes. And it's a very important little part of the brain. There's a lot that happens in that area. That's kind of, they call it like kind of our control center of the brain, like that hypothalamus, pituitary gland, that little combination, because, you've got a lot of signals going in and out of there, and they're affecting pathways all over the body.
Right.
And so that's where when we get really specific little tumors on the pituitary gland, it's like, depending on where it is, it's going to depend on, what the signs are and what it looks like.
Well, when you're looking at that hypothalamic pituitary axis, that's what controls homeostasis.
Yes.
And homeostasis is your body's ability to stay normal. So if you really think about it, it controls all of that. Funny story about that. I was fishing out in Montana this year, and there was these two older guys there, and I don't know why, but I swear, after you've been a vet, you can spot another vet, and not even if they're acting like one.
Like your spidey senses are tingling.
And this guy, we were sitting there at dinner. It was like the second time we've eaten dinner together. I was like, man, there's something different about this guy.
Like
I think he's a vet. Sure enough, I get to talking. He's a veterinarian. And he actually studies homeostasis.
Interesting.
So he's a research nerd, never actually given a shot before, doesn't practice. But yeah, he studied homeostasis. So he lived in this hypothalamus pituitary gland. That's just sort of where his life lived.
Wow.
When you think about it, one of its main roles is to maintain homeostasis in the body and maintain normal in the body. And this is at normal temperatures, normal body functions. That's what all this does. And then we throw a wrench in the plan, which is why everything goes
to crap. So, yep.
So older horses most commonly affected.
I think the stats that somebody gave me was there's 21% in horses over 15 years old, and greater than 30% in horses that are older than 30.
Oh, wow.
Yeah, that was the stat, which is kind of interesting. There was one kind of theory I read that how, like we were talking about homeostasis and preparing for things. And as we get into kind of talking about what some of these, symptoms are, a lot of it has to do with, horses kind of slowing down their metabolism and preparing for, winter to try to preserve some energy. And is this disease kind of that system going haywire?
Right.
Because of the disease process. And so it's like, or some of these processes that's like, okay, these horses are getting older. Is it part of a natural aging thing that's just making that process kind of accelerate? And it's like, never thought about it like that. But that was one of the theories.
That is interesting. So let's talk a little bit about the pituitary gland. 3 parts. You get the pars nervosa, pars intermedia, and pars distalis. It's really cool when you look at these sections on histopath. Maybe Casey can throw a picture up for people watching on YouTube, but it's I actually love looking at this on a slide because you can see the 3 distinct areas. And there's not like a line through them. It blurs a little bit, but when you stain them, you can tell it's different tissue. It's different tissue. And all those different tissues are secreting different hormones that go to different things. So in PPID, we're talking specifically about the pars intermedia portion.
Because I think it's the pars distalis in the dog disease. I think it's a different part of the pituitary gland.
It is, and it's more adrenal dependent because we're going to find out as we go through this that the hormone that we're talking about actually goes to the adrenal gland.
Correct.
And that's where the cortisol issues occur. And that's when it's going to get kind of cool when we talk about this, because the pars intermedia is not actually supposed to make ACTH.
No, it's not.
But yet we just call this pars intermedia dysfunction. So,
but when what happens with these is they get a benign tumor on this pars intermedia, and while that tumor is not necessarily aggressive and spreading throughout the brain, this tumor makes that pars intermedia start secreting this ACTH. And that ACTH is involved in the cortisol pathway. And cortisol is our stress hormone. Cortisol is secreted by the adrenal glands. And what is very unique about this disease is talking about kind of our feedback loops. So in your body, when your body is making hormones, at some point your body says, all right, we got enough. We got to turn the system off. And so there's these things called negative feedback loops, where you've got enough cortisol or ACTH floating around, and it tells your hypothalamus, say, hey, we're good. Let's shut this system down. And the hypothalamus normally in a horse will secrete a hormone called dopamine. And dopamine is what tells the pituitary gland to knock it off. In this disease, in PPID specifically, there is no dopamine. The dopamine is not secreted. And so therefore there is no off switch. And so we just keep ramping up. Yeah,
the way I like to think about it, so when we look at this, the pars distalis portion is supposed to make the ACTH. All of a sudden the pars intermedia starts making it.
Yeah.
And when we talk about that feedback loop, the best way I know to explain those is everybody, if you've got a horse, you've probably had an automatic water at some point in time. And if you think about it, it's kind of like the switch on your automatic water. As your tank fills up, it's going to push on that float. When it pushes on that float, the tank's full, it shuts the water off. The way when these feedback loops aren't working, in the case of PPID, it's like your float gets stuck, your float doesn't work anymore. Water tank fills up, the float doesn't turn the water off, and the water just sits here and just keeps dumping out and flooding everything.
Right.
And that's sort of what happens here, is we lose that feedback loop. These cells no longer respond to it. And there's even a backup built in where not only the dopamine control, but if you get enough ACTH, it's supposed to feed back to the pars distalis and say, hey, stop making more of me.
Which the pars distalis will.
Yes.
But the pars intermedia will not.
Yeah, it's like, no,
we're good.
I'm rogue. I do what I want to do.
Says more.
Yes, it just keeps on making it, just pumping this out. So it's pretty cool.
Yes, and that specific with the dopamine and that kind of negative feedback, that's very specific to the horse disease.
Yes,
and that's where we're like, well, hey, we shouldn't be calling it equine Cushing's. We need to be calling it PPID, because in the dog disease it's something completely different. It's a whole different thing, but. We're stuck with Cushing, so here we are.
That's how most people know it. So we're gonna keep trying to call it PPID, but this is gonna be years to get switched over.
Yes.
And the thing to think about, let's talk a little bit about that dopamine issue. Dopamine's a happy drug.
It is.
That's what makes you happy. When something cool happens and that good feeling you feel, that's coming from dopamine. And so one of the things you'll see in a lot of these horses, they get sluggish, they're dull.
Yes.
It's like, and I think horses experience happiness. I couldn't imagine they don't. The thing I think about is that pony that gets to buck the kids off. I swear they get a little dopamine hit out of that. But
or when they see their people and they get happy, you see them kind of perk up. We see it here all the time.
Oh yeah.
When the owners come to visit and they're like, "Oh, that's my people."
All of a sudden, horses' whole demeanor changes.
Yes.
And
for better and worse.
Yes. So yeah, that's because and that's kind of talking about one of the things we'll see with these horses is they're like, they just don't seem themselves.
Yes.
They're just not happy. And a lot of people don't notice that because it comes on really gradually.
Yes.
And then what we'll see, usually when we get these horses, we start treating them on the Prascend. What you'll hear people say is about 2 to 3 weeks in, it's like their attitude's different. Mm-hmm. They're brighter. They got dopamine back in their life.
Oh yeah.
So it's pretty cool.
All right. So what does this look like? I think we've all seen that very classic picture of the horse with the curly coat.
Yes, the hirsutism.
Hypertrichosis or long curly hair. And that's our word of the day is pathognomonic.
Pathognomonic. Ooh, we did not use that word on this podcast.
So pathognomonic is basically when you have some sort of sign, and like that is when you get that sign, there's only one thing that could possibly be.
Yes.
And that like long curly hair coat on like a breed that's not naturally going to have a curly hair coat, that is like Cushing's all day long.
Yeah.
There's nothing else that can cause that.
Hit a home run, you're good. Mm-hmm. You know what this is.
Yeah. So that's your vocab word for the day, people. Pathognomonic.
Pathognomonic. Mm-hmm. And you got to be a little careful about pathognomonic on this one with certain breeds.
I've had some, what's the curly breed?
The curly breed. Curly Baskin.
Yes.
Or Baskin.
I've had a couple of those trip me up before, and I looked at it, I'm like, what the heck? They're like, no, like that's the breed. I'm like, oh, okay, yeah. Okay.
And some of the Connemara's can do that too.
They can.
Some of them will get that real long curly hair coat. Mm-hmm. I've got a couple of those that you're walking in like, this thing's got Cushing's. Mm-hmm. And you see it, we'll see that like you're looking at it in February and like, this thing's got Cushing's. And they're like, no, he sheds out in the spring. I was like, no. And sure enough, you go back a month later and they're slick.
But if they look like that in July,
we have a problem.
We got a problem.
We have a problem. So, yeah, hypertrichosis, pathognomonic. Mm-hmm. You're seeing that long curly hair coat. Looks like your horse got a bad perm.
Yep. And with that comes this delayed shedding too. Yes. So that's kind of one of my first questions when, kind of especially this time of the year when everybody's kind of shedding out. We still see some of these horses that are looking real long and shaggy. I'm like, what are we doing, guys? Well, and are we shedding? What are we doing?
All those times people think I'm just petting their horse, and what I'm actually doing is I'm actually reaching up, seeing if I can shed, like grabbing tufts of hair and seeing if it'll shed out. And you're like, that's not going anywhere. Mm-hmm. And that's kind of one of the things that I use. Just like, is this trying to shed? Mm-hmm. Nope.
And so, or we get a lot that kind of have a very patchy shedding too. Yeah. That's kind of, I've seen how a lot of these early ones start is, they'll lose hair in some parts of their body, but then like their neck is just like shag rug. I'm like, okay, we got a problem here.
I would say they look kind of like buffalo.
Yes.
Have you ever seen buffalo when they're coming in spring and they're molting? Mm-hmm.
And even sometimes too, these ones that have had Cushing's for a while, they get that long hair coat, but it's not like good hair.
Yeah.
It's very fine. Like it's
dull.
It's dull. It's just, it's not like very healthy hair. Mm-hmm. So I'm like, that's again, kind of one of our, we're doing something here. So that's, one of our big kind of alerts to this. A lot of other they're very general signs. They can look like a lot of different things, and there's a lot of other diseases that do this. So muscle wasting and weight loss is kind of one of our big ones.
We need to talk about that because I can tell you there's a lot of people that talk about cresty necks and fat pads, and they're like, that's a Cushionoid horse. And yeah, you go back 15 years ago, we sort of grouped all these metabolic diseases into one, and we blamed, I think, everything on Cushing's because we didn't understand insulin resistance. We were still trying to sort through metabolic syndrome. But Cushing's actually causes muscle loss.
Yes.
And they actually they're poor.
Yes.
It looks like, and one of the things we'll hear is like, I'm feeding him, but he's not gaining weight. Mm-hmm. That's a big clue to me.
Right. Very, again, muscle wasting.
Yes.
And they can, and again, it's where it gets complicated because we do have a lot of horses that have both.
Right.
Or we have some that have insulin resistance or EMS, but they actually lose weight. And those ones are the worst. And we're not even going to talk about those today because
we're not getting into that. We're not opening that can of worms.
That's where you just throw everything out the window.
Right. But when you see like that failure there's no bloom and it's like they just don't look good. And you talk to them and you're looking at nutrition plan and there's adequate nutrition there. We shouldn't be having this issue and we're just not gaining. Again,
we got an issue.
Makes me start thinking Cushing's.
Yep. And then just kind of like we talked about, that generalized lethargy. We don't have a lot of energy. And even if they want to eat, they're not gaining that weight. Some fun vocab words: polyuria, polydipsia, PUPD. This is increased urination and drinking. Basically, this comes from cortisol makes you want to eat and drink, and it can look like a lot of things, but that one's a kind of easy one to miss, I think, kind of depending on the horse's living situation.
Yeah, unless they're in stalls where you're like, man, all I do is fill water buckets all day. But and the tough part about that is there's other things that can look like.
Right.
So again, not going back to pathognomonic, polyuria, polydipsia is not pathognomonic.
Correct. Yep. They sweat weird. I've had some that like have really weird sweating patterns.
Real patchy sweating,
or like they sweat a lot, like a lot by like doing almost nothing.
Right.
I've had those. And then the immunosuppression.
Big one.
That's a really big one. And that's kind of where I think a lot of these ones, especially if they don't necessarily look like a cushingoid horse, that's where I'm kind of getting keyed in of like, do you have some sort of underlying Cushing's disease? Because frequent hoof abscesses, that's a big one that we get. They get these like weird skin infections that like don't go away.
A lot of times you bring me an older horse with dermatitis, I'm running a Cushing's.
Yes, they get PPID like PPID test.
Yes.
That's just, they get these like weird things that they should be able to shake, and you're like, why are you still getting things? Or you culture like a fungus on these guys. If you get a fungus, you're like, yeah, that horse has Cushing's.
Yeah. And another place we see this is like non-healing ulcers in eyes.
Yes.
That is like, you get an ulcer that you're like, oh man, this thing's going to be done in a week. And you come back in a week and we've made no progress. I'm starting to go down that road because it's not just the immune suppression, but these horses also just don't like to heal.
No.
But if you think about it, we know that, I mean, we all love steroids, and we're talking about like the good steroids, not like the baseball steroids. Not baseball steroids. We're talking about the good ones, which I guess the baseball steroids could be good too for very long.
Depending on who you ask.
So, but we know steroids, which is a synthetic cortisol, basically. We know those are not good for healing.
Correct.
So it kind of makes sense because you get decreased fibroblast migration, and I love talking about fibroblasts, but they don't heal well at all. So wounds that should have healed by now and just not, eyes that won't heal. That's a big one. Sinusitis
is the other one that I see.
Yes.
These things, if they've got a bad tooth in their mouth, they will get the nastiest sinusitis you've ever smelled in your life.
Well, it's interesting you bring that up because, a lot of these horses with Cushing's also can have dental pathology. And one of the new things that's come out is do not pull that tooth until you have that Cushing's under control.
Right.
Because one, you can't get rid of the infection. And then two, they don't heal.
No.
And so, and the mouth will not, and the mouth loves to heal. That's the beautiful thing about it. But we've even seen like, hey, it's not going to heal if you have Cushing's.
No.
So,
especially if you have uncontrolled Cushing's.
Uncontrolled Cushing's. Uncontrolled. Yeah. So yeah, it regulates a lot of things in the body. And like I said, skin's a big one. Their skin just looks terrible.
Bad. It's like flaky and dry and like thin and
it's almost like I find it a lot just on skin issues.
Yes.
And
very true.
Because and where I get in trouble, or not in trouble, but where it kind of escapes getting an early diagnosis a lot of times is a lot of the horses I work on, they're clipped.
Yeah.
And so they're constantly body clipped.
So you don't see the hair.
Never get to see the hair. And so they keep these horses clipped. Don't get to see the hair. One of the things that I'll pick up on is the farriers will tell me like starting to get kind of stretched, and they'll talk about the white line starting to get stretched out. And this is a foot that's maintained a beautiful hoof structure, and all of a sudden they look and the white line is getting a little bit of a stretch to it. And sometimes the farriers will mention that to me, and I'll start looking because, as we know, like one of the other big issues with this is laminitis.
Yes.
And a lot of those horses, when they start to get some of that stretching, they're actually sitting in like a low grade, I don't want to say laminitis, let's call it lamellar inflammation.
Okay. Yeah. It's in the umbrella.
Yeah,
but
we're gonna, technically it's laminitis, but it hasn't gone to full blown. This is turning bad. So yeah, that's a lot of times that's where I pick it up in a lot of these older show horses, is the fear, like I can't maintain this foot. It's flaring. It does not have the same structure it used to. And they'll tell me that. And because a lot of times those horses are clipped, so we don't see it in the hair growth, but we will see it in the foot growth. So
interesting. Very interesting.
Yeah, that's one of the places that I find it.
Because and it's again interesting too, because you're looking at a lot of population of like our big performance horses,
right?
And even some of these older ones that are competing well into it, they can still have Cushing's. Yeah,
I have a lot of them that especially they get into that late teens, and that's where the game's changed. Is used to, if you had a 20-year-old horse, you had a really old horse. I've got horses that are still having great careers at 20 years old, and so it's you don't pick up a lot of those things,
right?
Because they are kind of in a show situation, so they're staying clipped, and you don't pick up on it. So
interesting.
Yep. A little fun fact. So yeah, clinical signs, they can vary. Something that we have to vaccinate twice a year in the Southeast. The rest of the country has to do it once a year. We got to do it twice a year. But I think every horse needs that biannual exam, especially when they get older.
Yes.
And one of the things that we're actively looking for during those exams is, are we picking up on some of these signs that we may be looking at Cushing's? We're seeing them spring and fall, getting those vaccines done, but we're also doing that physical exam. And because this isn't like an overnight change in the horse, a lot of times the owners may not pick it up as soon as we do. We're like, wait a minute, this doesn't look right. Right.
And especially in these horses that we've known now for several years, and I'm watching them and I'm like, we're losing some body condition. Our coat isn't shedding out where we need to, we're slowing down a little bit and beyond what should be just normal aging. It's like, hey, maybe we need to do something about this.
Yes. So let's talk a little bit about testing.
Yes.
Because that's, I'd probably say that's one of our biggest limitations, or one of our struggles is, I can think of 5 different tests. Now, granted, most of us are only running one now, but I can remember when I graduated vet school, there's 5 different tests.
Yes.
And the one thing I tell everybody is that anytime there's 5 tests for something, it means none of them are good.
Right.
If one of them was really good, we wouldn't have the other 4. So, but now we've kind of all settled on to what we feel like is the best means. Right.
And even then it still has some limitations.
It does.
So what we're talking about is testing ACTH levels. Because what we talked about earlier, this the pars intermedia should not be secreting ACTH to this level. And so if you have an increase in ACTH, ergo you have Cushing's. It's not that simple, unfortunately.
No.
So ACTH is a very interesting little hormone, and there is a natural seasonal increase of it in the fall. And so we have parameters for what an ACTH should be in a normal horse from like January to about August. And then we get into a lot of gray area, because like what we kind of talked about earlier, some of these changes like growing out a longer hair coat, changing our metabolism, that's all something that some of these horses are going to do in kind of preparation for going into winter to try to conserve energy, to try to, prepare themselves. And so the body is going to just start pumping out more of that hormone as it is. And their baseline can live kind of anywhere.
Right.
And it can live very high and they can still be considered normal. And so that kind of affects when we're going to do this testing and how we're going to do this testing.
And I'm going to tell you what the topic we're about to get into, I don't think it could be any more opinionated among veterinarians than this one topic.
And like we've had talks about it too, like in here about like, well, should I run this test? Should I not run this test? Should I do something else? I've gotten like weird results from things, and somebody's told me to do one thing and another doctor's told me to do something else. And I'm like, I don't know, but
I kind of say I'm going to live on the hill of, it should not be above the normal range.
Correct.
Period. End of story.
Correct.
So if we're going into fall and we know we get a seasonal rise, a lot of the data is showing that those horses, they're starting to get that seasonal rise. And I hate this term. They call them pre-Cushings.
Yeah.
And I always look at it like, aren't they all?
Mm-hmm.
I mean,
per the stats, yeah, kind of.
I mean,
you got more than 30%.
I always like look at it like they're it's like people. You're pre-hypertensive. You live long enough, you're going to have blood pressure issues. You live long enough, this is coming. So I hate the term pre-Cushings because it's like every horse is pre-Cushionoid.
Right.
I mean, at a year old, they're technically pre-Cushings. Mm-hmm. So I just don't like the term. But for me, like if I've got baseline that's high in the fall, I'm treating that horse. So, and this is where it gets tricky though, because some of these horses, even though we have a seasonal increase, or even though they do have all the clinical signs of PPID, they'll have a normal resting baseline ACTH.
Yes. And so that comes in is our TRH stimulation test.
Yes.
Or thyroid stimulating hormone, or I think it's thyroid responsive hormone. Yep, thyroid responsive hormone. So this hormone is, in a normal non-Cushionoid horse, should not do anything to the ACTH pathway. But if you administer this hormone to a Cushionoid horse, that little pituitary gland is just going to start firing off more ACTH.
Within minutes.
So we do kind of what we call a dynamic ACTH. So we take a baseline sample, we administer the drug, and then at 10 minutes, or there's another test where you can run it at a 30-minute interval. We mostly do the 10-minute test. You take a second sample. So we call it our pre and our post samples. And it's how that ACTH changes in that 10-minute window that really tells us what's going on.
Right.
So we have some of these horses, yes, that their baseline is sitting at a normal level, but we give them this hormone, and now all of a sudden, I mean, their ACTH is like 200 something. I think you had one the other day that like
I hit over 800.
It was like some like tenfold increase. I was like, whoa. Yeah, that's a Cushionoid horse.
Yeah, and it had a normal resting.
Yes, it did.
I think it had like a 26 on resting. It stemmed over 800,
which is insane.
Yeah, it was that made the Wall of Fame.
It did. Yes, it
made the record board. Mm-hmm. But yeah, and that's where testing has progressed, is because when I was just getting out of school, the best test we had was just a baseline ACTH. Mm-hmm. And even then we were only dealing with we could catch about 60% of them. I think that was the stat. It's like 60%. And I think that might have been an overstatement, because I can't tell you how many horses that we check have normal resting ACTH, and then we stem them and they have these massive stems.
Right.
One of the older tests used to be, we looked at dex suppression. Yes. That's the test of choice in dogs, where you measure cortisol level, you give a dose of dexamethasone, you come back and recheck cortisol. That test, I think, is less than 40%.
Yeah.
It's pretty terrible.
They taught us about it in school, but they're like, nobody does this. Not realistically.
No, nobody does. And so having this TRH stem has really increased our ability to figure this out and catch it sooner.
Yes.
Catches, because I believe if that ACTH gets above baseline, you've had this for a while, because you have enough of those cells that have gone rogue in the pars intermedia to where you're cranking ACTH just gobs of this stuff. With the TRH stem, we can catch it much sooner.
Right. And again, it's not a perfect test. Nothing is. I had one that I swore up and down. I was like, this thing's Cushionoid all day long. And I got it back, and my baseline and my TRH stem were completely normal.
Right.
Nothing happened. And I actually called an internist and I said, what happened? Did I do the test wrong? And they said no. Because again, the pars pituitary doesn't normally secrete ACTH, and it's very variable what it does. But we think that there's a lot of other hormones that are being pumped out right now that are in this pathway and causing these cushingoid signs. We just don't know how to measure any of them right now. ACTH is the only one that we really have a good, reliable way to measure. Because
really, ACTH is a pre-hormone.
Yes.
It's actually causing the release of another one called POMC. Preoperionic melanocortin.
Wow.
Preoperionic melanocortin hormone.
That's pretty good.
And that thing's cleaved into like 6 different peptides that have 6 different effects downstream. All those also have feedback loops. And so it can get, when you're talking about the endocrine system, it's the most complex, simple system you've ever seen. Because I mean, it only does the hormones only do like 1 or 2 things. Yeah. They all have these negative feedback controls, which is really simple. You filled the water tank, shut it off. But yet they all have these downstream effects that can make so many different things happen.
Yes. The way that we talk about it and kind of, teach it to clients, and even we try to really understand it ourselves as just general practitioners, we're talking at this at like a baseline level.
Oh, yeah.
But like you get into the nitty gritty of it, and there is so much going on in the body.
Right.
Like,
again, this controls all the homeostasis.
Yes.
All the normal functions throughout the body. So, and you're right, because I mean, I've had horses, I'm sitting there looking at them, they've got hirsutism, they've got bad skin, they've got muscle wasting, they've got a dull personality. They have literally got everything but a big sign that says, I've got PPID. And then you'll test them.
Nothing. You got nothing.
And that's when you've got to go with, I always say that's when you just got to put your doctor hat on and say, look, I know I'm only going to catch about 80% of these on the test, or I can't remember what the stats are now, but maybe a little better than 80%. But you just got to go, there's clinical signs say this is what I have.
Right.
And you know what, we're going to treat.
Exactly.
So, well, let's kind of delve into that a little bit when we get into treating these horses. Really, we've got one medication.
Pergolide. We love pergolide on this podcast.
Yes. I say no drug has helped a horse more than pergolide.
Yes.
Because and one of the things I've seen is as the equine community has gotten more aware of this condition, we're testing sooner. We're diagnosing this sooner. The amount of laminitis we see has dropped precipitously.
Yes.
I can tell you when I'm a podiatry guy, the number of horses I used to have to manage the laminitis on with these. And we're going to get into more specifics as far as medications. Like we used to always have was compounded pergolide, which has crap stability. You never knew, like you may be giving them 1 milligram, but you may be dealing with 60% stability. And the stuff will be all over the place, which is why we will not use a compounded pergolide.
No.
I will not write a prescription for a compounded pergolide. I will not sell compounded pergolide. Period, end of story. I think it's a crap drug. And because I lived with it for so many years, it's all we had.
Yes.
And I can tell you, it was every time I gave somebody a new bottle, it's like within the first week or two, I knew I was going to get a phone call. They're not doing good, or we got to bump this up. And we never regulated. Never once got regulated. We were all over the place. When Prascend came out and this stuff was stable,
changed the game.
And you gave them 1 milligram and they got 1 milligram, life changing. The amount of laminitis we saw dropped.
Wow.
It was phenomenal.
Wow.
So go BI. Thanks for making that drug for us. So, yeah, so pergolide, let's talk about
pergolide. So pergolide is a dopamine agonist because we go back to beginning of the podcast with the big thing that makes this disease what it is that the pituitary gland isn't responding to dopamine. So we put that dopamine back in, we return that off switch, and we can kind of calm everything down.
So when we talk about dopamine agonist, what agonist means that we're going to stimulate.
Yes.
Antagonize. I don't know if that's where it
Agonize. Antagonize would mean we calm it down.
That's right. Antagonize, we call it. Agonize. Yeah, anyway, it's going to make more of it. I don't speak Greek, so yeah, we're gonna basically make more dopamine.
Yes, we're gonna make more dopamine. We're gonna add in a dopamine-like thing to kind of return that off switch. And and Prascend is our big player in this. Prascend's been around for a while. it's wonderful. There's actually a new player in the market. Zygolide just came on the market within the last couple of months. It's produced by Decra. It is the first generic version of that. So, and we've kind of talked about this on the podcast. There's brand name, there's generic names, and then there's compounded.
Right.
So, the kind of main difference is that you've got the brand name. They're the ones that kind of probably originally made the drug, and they've got that. The generic means that it's being made by a different company and it's under a different name, but it's the same drug.
They copied the recipe.
They copied the recipe. So it's kind of that next, version of it. Compounding is where we are producing the drug in a different format than what it was originally came out. So there's, I think, injectable pergolide out there. I've seen powders. I don't know if there's a paste, if somebody's doing that, but...
No, we used to use an oil-based liquid.
An oil-based liquid, okay.
Because the hope was it wouldn't oxidize as rapidly, because we're going to talk about that.
Yes.
But yeah, so it's a big distinction, because a lot of people say, I want the generic, and what they're really talking about is a compounded. And that's just made in a pharmacy. They order an active ingredient, they mix it with some stuff, and then put it in a different form.
Right.
It's not manufactured in a manufacturing facility. And I'm not bad-mouthing compounds, because Lord knows if we didn't have compounded pharmacies, we wouldn't have half the medications on our shelf.
Correct.
So not doing that at all. But there's not the quality controls are different.
Right.
They still have some, but this drug not only has to be made safely, but it also has to be shown to be effective.
Yes. And even the Prascend is a very unstable drug.
Right.
So it comes in these little packets that are wrapped in foil. And when you pop that foil, that drug needs to be used within 24 hours.
At least.
At like bare minimum. Like they even say the second you pop that, it goes into the horse.
Right.
So, they include it on the label. And I tell everybody that I put them on, I'm like, hey, if you're one of these people that likes to make all of your horse's food, do not pop that tablet.
No, because it's actually sealed. That's a nitrogen gas that they actually seal inside there to drive out any oxygen. When this stuff hits oxygen, it
immediately starts breaking down.
Yeah, it's not happy. And so, and I always tell people, like, no company wants to make those full packets. They want to take a bottle and stick 500 tablets in there.
Yes.
That's very cost-effective production. Making individual full wrap packets, that's not cheap.
No.
And no company wants to do that because it just drives the cost up.
Right. And the only reason they're doing that is because they have to in order to preserve the drug.
So do not try to make up. And that's probably one of the biggest failures we see when people are like, they're not responding. Well, then you go out and investigate and there's a week's worth of feed bags. They're popping the Prascend out early, putting it in there. And you're like, oh, this isn't a drug failure. This is a failure of administration.
Of handling, right. So but again, I try to tell everybody that. And I think it's on the label now. Like, I think it needs to be bigger on the label. I think it needs to be just in big letters, be like, do not pop these, please.
And so with the addition of Zygolide, we are seeing a little bit of a decreased cost of that treatment.
Yes.
I'm curious to see how well it's going to work. Like I just learned about this. I was not aware of this.
Yeah. It's brand new. Like it's within the last probably month or two.
Right.
So it's a brand new drug. I, have just personally started trying it on some patients. So I'm curious to see, but I've talked to a couple other doctors that have tried it and, they've had good things to say about it. So,
because you never know, like when you get into the generic world, generics have to be, if I remember correctly, they can only be like a 10% differentiation from the original product. So there can be some variability that's allowed with a generic. There's certain drugs we can go generic. Like if you think about Butte, I don't even know who first made Butte. I think technically every one of them is generic now. But you have other medications like Atopica is one used, and it is cyclosporin, but you cannot use a generic cyclosporin. You have to use an Atopica. And so there's some that we can go generic, some we can't. So I'm really curious to see how this works.
Yeah, I am too. I think because again, that's what it comes down to is cost, because this is unfortunately one of these conditions that when we diagnose it, your horse has this forever.
We do not cure it. We manage it.
Yes. This is your horse is going to have this for the rest of their life. And, given a tablet every day, that can add up.
Right.
And, and this medication's not the cheapest one we have. It's not outrageous, but it's, if they're going to be on it for, the next 10 plus years, that adds up.
And I will tell you, like, if you look at cost, it is still way less expensive to manage this condition or treat this condition than it is to deal with the after effects.
Correct. That is true. Unmanaged Cushing's is very expensive.
I always say if you can save yourself one vet visit from like laminitis, you can buy a lot of percent for the cost of getting through a laminitis case.
Correct. Yes.
Even if you're dealing with a really bad dermatitis, secondary to Cushing's, it's going to still be more cost effective to manage this than it is to deal with the after effects. So really from a cost standpoint, it is very advantageous to treat this.
Yes.
So that's really important.
And this medication can take some time to kick in. We say that we have to give it 60 days to really make or break a difference. I think you said earlier, like we get some calls in like 2 weeks. They're like, oh my God, they're a different horse. Like they're wonderful. But this drug can also have some side effects. I'd say the biggest one I see is inappetence. Yep. They don't want to eat on this. Sometimes with these guys, if I, get a call in that first week, we've started Prascend and they're like, hey, they're not wanting to eat. They just seem a little more down. I'll say, let's cut the tab in half. Let's go with a half dose for the next couple of weeks. And then, at 30, 45 days, we can try to up them again to the full. Because it can be a lot. Dopamine it's a powerful little molecule and it can do a lot. So.
Yeah. And that's one of the things I actually love when we have ones that are, their baseline ACTH is high because we can start them on the Prascend. And the cool thing is we can go in and retest those horses and then see if that ACTH is being controlled. It gets a little more difficult when we're dealing with the ones that have a normal resting ACTH. Yes. Because then it's like, okay, we go in and retest those horses 6 weeks in and their ACTH is normal. You're going,
did it work? Did it not? I don't know.
You're not going to restem those horses. But so I agree. The biggest thing I've seen is not wanting to eat, but I'd probably say 99% of the horses that didn't want to eat on Prascend, we cut the dose in half.
And they do fine.
And they go in and do fine.
Yeah.
And I'm sure there's going to be somebody out there that say, well, my horse didn't. Well, okay, you're the 1%.
Yeah, sorry.
But the majority of them, they're going to get better. We cut them down to half. They go back to eating. Life's good. There are a few subsets. I've had, I think, one horse that just absolutely could not tolerate it. Wouldn't eat. No matter, like we cut the dose in half. Couldn't eat. Got really bad diarrhea. Nothing I could do. And we're like, well, here we go.
Yeah. I mean, there's nothing you can do in that one. I'm like, nah. But
that's one out of
hundreds.
How many thousands we've treated? It's a lot.
Yeah.
At least over my career, there's been a lot. So, yeah, it's a fantastic medication.
Yes. And these horses can go on to live a very normal life. We have a lot of horses that are on this and they're still out there doing lessons, showing,
once it's controlled, they do great.
They do fine. They have an absolutely wonderful time. Sometimes they still get a little hairy and they, if you got to body clip them in the spring, they can still take a little bit longer to shed out. But, all the skin things, they do a heck of a lot better with that. Our horse that we had with the big skull fracture, that thing had... Oh, his Cushing's was apparently so bad when they first got him treated, and I was so nervous when we were doing that. But his face healed wonderfully.
It did.
I was like, all right, look at you, old man.
And we'll touch a little bit on dietary management because that's what people say. Well, he's got Cushing's. What can I feed him?
That's a loaded question.
I'm usually like, well, if it's just Cushing's, anything you want.
Yeah.
Like that's the problem is not a nutritional issue. The problem is what the body is able to do with the nutrients.
Right.
And so once we get the Cushing's control, they can
eat whatever.
Eat normally. It's not like we don't need to, because a lot of people want to put on these low sugar diets with Cushing's. And I'm like, no, we need to gain weight.
Correct.
Carbs is how we gain weight. So we need some carbohydrate. We need some protein. We have to gain. And so it's not, now if they have, which we're not touching on, if they have one of the other metabolic conditions, well, that's a different thing.
That's a different thing, right. And again, for a long time, I think people just bundled all of that together.
They did.
And so they said, oh, if my horse has Cushing's, they can't be on grass, they can't have sugar, they can't have all these things. I'm like, no. Not necessarily. If all we've got is Cushing's, like, you're on the Prascend, you're good to go. Like,
yeah, you're on Prascend, let them eat.
Yeah, they can have whatever they want.
Let them eat. Mm-hmm. So, yeah, one less thing to have to worry about.
Correct.
Correct. So yeah, I think, kind of summing things up, having these horses checked, don't be afraid to run. Like, we screen a lot of horses. They get to a certain age and it's just kind of part of our yearly thing. We're going to start screening these horses because we want to catch it before we have an issue. And just because they were negative the year before does not mean they're going to be negative the next year. It's not they have it or not. Like, this is something we may have to keep testing.
And especially if we get one of these test results, if we test them and they're kind of in this gray area, this, quote unquote pre-cushionoid state, I'll be like, listen, like you said, this is a progressive thing. Next spring, we might be a little more in that range, but we're not going to treat them right now, but things change.
A lot of times I'll get those horses if I'm suspect and my test is kind of showing me that I'm kind of on the bubble. I'm prone to get them. Just go ahead and start treating because I hate laminitis.
That's fair. Because
the laminitis I've had from these, until you get the Cushing's controlled, the laminitis doesn't get better. And so the ones that walk in here, their feet are in terrible shape. They're laminitic. And I realize this Cushing's causing it. Like, I know I am 6 weeks before I can start to make progress. I have to somehow hold these feet together for 6 weeks. And I've got to keep them alive and these feet on the horse for 6 weeks until my medication kicks in.
And see, I'm the opposite because I've had a couple horses that were put on Prascend that didn't need it.
Yes.
And they hate their life.
I agree 100%.
And I've taken them off of it, and they're like a new horse.
I've had a few of those, which is why I think...
Again, it comes back to the testing. There's so much, like, that, is very... I think one thing, you might think something else, and...
Well, I think the other part of that I should have said is, like, it's not just testing yes or no. Testing and clinical signs. You got to put your doctor hat on and interpret this.
Right.
If I'm in that kind of, maybe I am, maybe I'm not, but clinically this is what I have, yeah, I'm going down that road. If I'm in that situation where I got that bubble line test, but I've got no other clinical signs, I'm holding off. Because again, I've seen the same thing, and it seemed to be the past year. I felt like I had 5 or 6 of those where they just weren't doing good. And then I found out they were on Prascend, and I'm like, hold up, this test is it's a little inconclusive.
Yeah.
Let's just come off of it
and see what happens.
And we'll retest, but let's come off of it. And you come off of it and their life gets better. And like, that's, if you put them on it and their life gets better, it's probably PPID.
Probably, but
if you put them on it and their life gets worse, probably not. Because again, dopamine's
a weird drug.
It's a weird drug. So I think, and that's the one thing I remember we did a deep dive trying to find out, like, what's the slam dunk on a test. And every internist we all talked to sat in this discussion. They all said the same thing. You have to interpret the test in lieu of clinical signs. Right. So again, this isn't a chat GBT deal. No. This is some doctor stuff.
Yes. And it goes back to kind of, the big philosophy when I was in school was you treat your patient, not your lab work.
100%.
And like, I mean, and you can say that about so many things, but I think it really does come down to that. Like,
yep. Early diagnosis, accurate, interpret correctly.
Yes.
All those things lead to a very manageable condition. So I can remember I hated this disease. I still don't like it, but it's like,
And it's not a death sentence.
It's really not.
It's not. We have a lot of horses running around on Prascend right now. We have a lot.
Fantastic.
And they've never looked back.
So, Well, good deal. Well, I think it's a really good topic. I know we kind of covered it briefly in one of our previous episodes, but I think it's definitely worthwhile diving in. So if you're concerned about this, make sure you talk to your vet. Having those biannual exams, because like I said, this one kind of creeps up on you. You may not be noticing it just because it's a slow, progressive change. But having those biannual exams and having somebody that maybe doesn't see the horse every day.
Right.
You'll pick up on this a little bit sooner.
And right now in the springtime, this is a really good time to test for it.
Very good time to test.
Kind of our least amount of gray area that we have.
Right.
So if you're concerned about it, or you're hearing this podcast and you're thinking about your own horse and you're like,
yeah,
this sounds a little familiar.
Talk to your vet. Run the test. Talk to your vet. So, well, thanks for being here this morning. I really appreciate it. April, thanks for recording all this. Casey, thanks for doing the editing. To our listeners out there, we really appreciate it. Y'all, it's kind of fun seeing all the comments come in and hearing the topics. Because like I said, this is one that got sent in and said, can you tell us a little bit more? Can you do a little bit deeper dive? So y'all keep sending those in. So it's to ask y'all to like and subscribe. Like and subscribe. That kind of tells us that, hey, people are out there actually paying attention. So
share it with your friends.
And like I always say, if you don't want to like and subscribe, don't. Just keep listening.
Yep.
We're just doing this it's fun for us. We want to educate the world. And so.
If you're listening on the Artemis, please listen to us so we can be the podcast in space.
Oh, that'd be so cool. That'd be so cool.
Wouldn't that be cool?
I wonder if they have podcasts in space.
They got to do something.
I mean, surely.
I mean, they're floating up there for like a good week and a half. Like,
yeah,
I'd download some podcasts.
Yeah, that'd be really cool. Space cowboys up there.
Yeah.
All right. Well, y'all have a great week, and we'll see y'all next week. Take care.
Bye.